So why don't we move on to impingement of the shoulder. And we talk, there are a number of different impingement syndromes. We're going to start out with kind of outlet impingement or acromioclavicular type impingement. We'll talk about pathogenesis and then what it does to the tendons. So types, so there's acromial impingement, acromioclavicular joint impingement, anterior impingement, and internal impingement are the primary ones we're going to talk about. So the classic one also is called near impingement. Charlie Neer was an orthopedic surgeon in New York for a number of years who, and other people before him, really popularized this. But he described 3 stages that he could see surgically. This is primarily open surgery, which you have with impingement, and this was primarily looking at the supraspinatus tendon. Stage 1, you would just see edema and hemorrhage in the tendon. Stage 2, fibrosis and tendinitis. And in stage 3, you'd see a lot of bone spurs and tendon rupture in that area. And we'll be talking, now we don't really use this staging system anymore. The changes we see within the tendon are now primarily attributed to direct strain injuries of the tendon rather than due to bone impingement, but we'll be talking about the bony impingement here as well and some of the surgical treatments that are used to try to correct for it. So the anatomic things that we see with imaging that increase the risk for acromial impingement really are a type 3 acromion, anterior sloping to the acromion, lateral downsloping, inferior placement of the acromion with respect to the distal clavicle, and a distal positioning of the musculotendinous junction of the supraspinatus tendon. So looking at the acromioclavicular joint, we primarily look at osteophytes and also callus formation at the acromioclavicular joint. Either of these two can press down upon the supraspinatus tendon, rub it, irritate it, and produce symptoms. So one way to look at the acromion, the three types of acromion were initially described in the orthopedic literature using the outlet view by plane radiography. We kind of took a similar approach using the oblique sagittal imagings to look at the shape of the acromion. So type 1 acromion is relatively flat. There's usually a little gentle curvature of the acromion process above the humeral head. This is anterior, this is posterior, and we don't see any inferior projection of the anterior margin of the acromion. So this would be a type 1 acromion. A type 1 acromion with plane radiographs using the outlet view has a low correlation with impingement, and so does a type 1 by MR. A type 2 has a more of a gentle curve, which we see here, without any eburnation or real osteophytes underneath it here. And this is kind of what you see on the outlet view on plane films. The outlet view of plane films is thought to be an intermediary risk for impingement. The type 2 acromion on an MR scan does not create increased risk for impingement, this gentle kind of curve. Type 3 acromion can either be due to a congenital abnormal shape where you have a bump on the anterior aspect of the acromion, which abruptly narrows the interspace between the acromion process and the humeral head, and therefore can rub the supraspinatus tendon in this location. This is usually the anterior margin of the supraspinatus tendon. Or you can develop an osteophyte, either from degenerative disease of the acromioclavicular joint or due to chronic traction injury of the coracoacromial ligament, where you get the osteophyte growing out alongside the ligament. And that both of these can produce an abrupt narrowing of the acromiohumeral distance. John?
That one on the left is some people call a hook.
Right. Hooked acromion, right. Good. And this is, so this would be congenital, this is more acquired. Here's a more common appearance of the acquired type lesion, and you can see where this is an acquired osteophyte right at the insertion of the coracoacromial ligament here, and this is generally thought to be chronic traction injury. It stimulates a healing response, which, as we've talked about many times, is much more efficient from the bone, and then the osteophyte grows along it, just like osteophytes that we see elsewhere in the body. That's an acquired type 3. So this would have increased risk for impingement, narrowing the space here, and we can see some abnormal increased signal intensity within the underlying anterior margin of the supraspinatus tendon. The other thing that we look for is eburnation and irregularity. Here we can see these are also acquired osteophytes. You can start getting marked thickening of the inferior surface of the acromion process here. When it gets very irregular like this, you can just see how it could rub against the supraspinatus tendon, and that can produce increased signal intensity along the bursal side surface of the supraspinatus tendon, which can lead to tendinosis and then to partial tears and eventually a full thickness tear. And we can see the increased signal on the axial T1s here. So that's another thing. And it's kind of like if you take a saw and you take off all the teeth, you can try all day long to saw through the log and you're not going to saw through it. But if you have sharp teeth like this, then you can readily saw right through the log. So that those irregularities and those osteophytes can increase the risk that you would irritate the supraspinatus tendon from just normal mechanical work. And here's an example of a lateral downsloping, where instead of the acromion being horizontal, it slopes down. We have eburnation of the inferior surface due to the chronic irritation from the underlying tendon. And here we can see increased signal intensity and thickening of the superior margin of the supraspinatus tendon due to the irritation from the bone. And then we can see an associated effusion within the subacromial subdeltoid bursa. And here we can see it on these two T2 weighted images. And on the sagittal T2, you can see the marked irregularity of the bursal side surface of the supraspinatus tendon anteriorly, right where that bone has been impinging upon the tendon. So this would be outlet impingement. And here, just another example where we can see the bursitis, the marked irregularity and eburnation of the inferior surface here, and a little bit less, but some irregularity of the supraspinatus tendon. Now, in the pre-MR days, Neer felt that the vast majority of rotator cuff tears, which tend to occur in this location, were due to the impingement process. So a very common procedure in those days was to go in and do an acromioplasty if the osteophyte was from the acromion, or a Mumford procedure if it was due to osteophytes at the acromioclavicular joint. A Mumford procedure, which we'll go through here, is a distal resection of the distal 1 centimeter roughly of the clavicle at the AC joint. To get rid of that. And this is just another example of a little bit of lateral downsloping, eburnation, and the secondary irritation of the bursal side surface. But in the late 1980s and early 1990s, what was found is, in pathologic studies, is that the bulk of tears and partial tears really tend to primarily form from the joint side surface rather than the bursal side surface. And then some other studies really started emphasizing that most tears of the supraspinatus tendon are probably not caused by outlet impingement, but by primary tearing of the collagen fibers of the supraspinatus tendon, probably from repetitive traction injuries. So the acromioplasty as a lone procedure really isn't performed as much as it was in the past. And a lot of this comes from arthroscopy data, where they could see early changes in the tendon arthroscopically that you really couldn't back in the days of open surgery. John, do you want to comment on this?
There's really not much to say other than it's you showed the saw sawing wood. It's a little different than a saw sawing wood. Actually, it has little prominences rather than sharp points. You can actually take your finger and go underneath the acromion, and you'll feel the bumps.
Okay.
But you won't feel anything sharp.
Right.
But when you look on the MRI, much rougher, but you're missing the other inserts of the bone. It's really fairly smooth. Otherwise, it would have gone. You'd lose acromion within a week.
Okay. And but you can also
or the tendon.
And you can actually get irritation of the bursa with the chronic bursitis, even with less prominent changes. Okay, so this patient had trauma a year ago, and here we can see not a lot of downsloping, not a lot of osteophyte formation. We can see a high-grade partial tear of the supraspinatus, and then a lot of fluid within the subacromial subdeltoid bursa. So this is primary bursitis here, and in this particular patient, and this can also be associated with outlet impingement. And here's just an example of a partial bursal-sided tear of the supraspinatus associated with this inferior osteophyte and eburnation of the acromion process. The other thing to look for is lateral downsloping. We like to see the acromion process as horizontal, but it can also slope downward. And this is really something that really was emphasized more in the MR era. Yeah, this is a term that I started using. I'm sure other people may have used it even before me, but I don't remember that. I just couldn't figure out another single word to use for this. This is mild, and this would be within normal limits and not enough to really increase the risk for impingement. It's really when you see the lateral downsloping with the eburnation and osteophytic changes that we talked about before that it really has an increased risk for outlet impingement. And here we can see the bursal side partial tear of the distal insertion that goes along with it.
I think Nair called this downsloping type 3 acromion.
Good. Okay, great. That's good. And then here's another example of downsloping of the acromion. A lot of eburnation here of the inferior acromial surface. And here you can see that the normal cortex would probably go right around through here, and this is all an osteophyte on the inferior surface of the acromion. It's rubbing the bursal side surface of the rotator cuff, a little bit irregular here, and all this bursitis which goes along with the irritation. Another finding that can correlate with impingement or when you have osteochromiale. And here we can see, especially if they're unstable like this, where you have a lot of fluid between the os and the acromion process. The important thing that you're all familiar with is don't mischaracterize the normal physis of the clavicle with an osteochromiale. As you know, this tends to fuse around 22 to 25 years of age. A lot of people say don't call an osteochromiale if the patient is under 25. The thing is that the actual physis here has a very different look to it than an osteochromiale on MR. You can really characterize it better. So there have been times when I've called osteochromiale even when people have been under 25 because it's clearly abnormal. So that's a normal physis. There are words for exactly where the separation between the bones occurs, and these are different parts of the acromion process. I've not found these words very useful. John, do you like to use these to characterize the osteochromiale?
No, I don't.
Yeah, so I just give the size of the osteochromiale, and I don't go back to these words. But you'll see this in a lot of the. Yep.
I really don't use them. I just.
Okay.
I go clinically. If it needs surgery, I'll do it.
All right. Okay. Another thing to look for is inferior placement of the acromion with respect to the distal clavicle. And I don't know if these are due to old trauma or whether this is congenital, or presumably it could be both. I just kind of presume that this is congenital. And you can see instead of the acromion process being parallel to the distal clavicle, it actually articulates underneath the clavicle. In this case, with a little bit of edema in this area.
Yeah, there are variances from birth, and you see that in kids. So this is congenital.
Okay.
You would know if it was trauma.
Yeah. Good. So this is something I just mentioned. If I see it in the report, if the acromion is impurely placed with respect to the distal clavicle. Okay. So here's another example. Here we can see the acromion. We can see irritation and increased signal intensity along the superior aspect of the supraspinatus tendon right at the musculotendinous junction. But what's abnormal here is notice if we go back to the most of the rest of the cases that the musculotendinous junction typically is located right about the 12 o'clock to 12:30 position of the humeral head. If it's more retracted than this, that's abnormal. It's generally associated with tears of the supraspinatus tendon with or without scarring of the tendon, which we'll talk about when we talk about the tendon. If it's more peripheral than that, that's an abnormality also. And another risk for impingement has to be when the musculotendinous junction is more peripheral than the 12 o'clock position of the humeral head. What can happen then is a very thickened portion of the supraspinatus muscle can get impinged between the acromion and humeral head, and the space is too small for this muscle, and this is also a congenital lesion. In this case, we can see that there's irritation of the musculotendinous junction, probably some irritation of the superior part of the muscle as well, in this case, and so I just call this a distal musculotendinous junction. Here's a more severe example of that, where you can see the muscle extending too far. This also occurs in other locations. We occasionally see this in the wrist and occasionally see it in the ankle, where it can also be symptomatic. There are other problems here too, but we're just talking about the subacromial region right now. So here the musculotendinous junction is way too peripherally, and this can be a problem. One of the first patients I ever saw with this was a professional wrestler who went around, and he could probably press 500 to 700 pounds above his head. The guy was huge, muscles were enormous, and he had no trouble in the gym. But when he went on trips, he couldn't carry his suitcases because they made his arms too painful. And what happened is when his arms are at his side, it pulls the supraspinatus muscle over here, and he got impingement of the muscle. When his arms were up, the humeral head rotated. He got tendon between the acromion and the humeral head, and he didn't have any symptoms. So this can be symptomatic. So how do you treat these conditions? If you have a hooked acromion, like John was talking about, the treatment is really an acromioplasty, where you can remove that hook and change it. And we'll go through, you want to be careful not to remove too much bone, or that can produce superior instability. And remember, when you take this acromion off, you typically sever the ligament here, the coracoacromial ligament that attaches in that location. So here's one example. This was before and this is after acromioplasty. And in this location here, the ligament still is grossly attached here. In this particular case, by MR, we did not call increased risk for acromial impingement, but because of the patient's symptoms, they did an acromioplasty anyway.
It's not recommended to do that ligament release anymore. It used to be.
Yeah.
The coracoacromial ligament.
Because that can
we leave it alone.
Good. Yep. And then here is before, where we can see a little bit of lateral downslipping, a lot of eburnation, and here's after the acromioplasty in this particular patient. Oh, I'm sorry, I did this wrong.
The acromioplasty. I'm sorry, I'm interrupting him.
Go ahead.
Acromioplasty used to be extremely popular after Neer published this article. I wish to hell wouldn't have published it.
Right. 1983.
Because a lot of shoulders were ruined because of it. It really doesn't do any good to remove the bone. It grows back, and it's pretty rough when you remove it, especially before MRI and before arthroscopic type of procedures.
Yeah. Open.
He published this article on sloping of the chromion, I think in 1983 or 84. I just can't remember.
83.
Well, I was close.
Yeah, you were. Right on. So this is a patient who had symptoms, and they did an acromioplasty. The patient continued to have symptoms, so then they did an MRI. And what we see here, there's an acromioplasty on the posterior aspect of the acromion process. But when we come to the anterior aspect, we still see a lot of eburnation. We still see irritation of the supraspinatus tendon here on the bursal side. And this was an incomplete acromioplasty because typically the symptoms for this disease, as we've been talking about, are always in the anterior acromion. And that's not the area where the acromioplasty was done in this particular patient. So that's why the patient continued to be symptomatic. Let's see, I'm getting tired of talking here. Shiv, what do you think of this case?
So it looks like we have post-surgical changes of acromioplasty. I see a fair amount of scarring, or what looks like hypointense material around the acromioclavicular joint, and there's still some small inferior osteophytes at the distal clavicle.
So this patient was still done. There's the acromioplasty. There's the osteophyte. And this patient continued to have symptoms because they didn't really completely remove all the areas of the impingement. This also is a fairly large, a lot of removal of the acromion, and there was some question about whether he was unstable after the acromioplasty as well. You can also see that there's some tearing of the supraspinatus tendon, which we can see better on other images, proximal retraction. Remember the musculotendinous junction, which is right about here, should be around the 12 o'clock position. So this is a big supraspinatus tendon tear with retraction of the supraspinatus tendon. But this was thought to be too large an acromioplasty and not removal of all the bony impingement. Pablo, you joined us. What do you think of this case?
Hi. Yes, we have a 45-year-old male patient with posterior shoulder pain and 4-year-old acromioplasty. So we see some changes of acromioplasty in that sagittal plane on the left side, and I see fluid. Let's see, there's thickening also in the coronal view with some hypointense material. So I'm thinking that there's at least partial tearing of the tendon there.
Yeah, I think
there's some fraying.
What do you think this is?
Yeah, there's that. I thought it was part of the acromion. It's kind of
so the normal
the extending more anterior. Yeah, it would end there.
So this is a huge osteophyte, right?
Osteophyte. I see. That's where the acromial ligament is.
Yeah, here's the acromial ligament here. There's the osteophyte coming down. Here's, again, retraction of the musculotendinous junction of the supraspinatus, a tear of the supraspinatus here, which we would see better on the PD fat sand images. But here we're just looking at the bony anatomy here. So this is a large osteophyte that's, I don't know whether it wasn't resected or it was resected and grew back, and then downsloping, causing persistent impingement here, which was the cause of the patient's symptoms.
Downsloping.
So, John? Okay.
So we have
it was probably saved on. I'm sorry. It was probably shaved underneath to give it more room, and it was shaved not aggressively, which is the proper thing to do. This surgeon did the right thing.
Okay, good.
This shows shaking of the others.
Yeah. Okay, so here's another case. This is before a chromioplasty, and here's after a chromioplasty. We can see kind of a general curve here. I would call this a general curve. Again, I would not call this high risk for impingement because it's kind of a gentle curve, though there probably is some osteophyte here. And here's the coracochromial ligament. After chromioplasty, they did remove the osteophyte, which is probably reasonable if they had the right symptoms. And you can see that the ligament was released as well in this particular process. And this patient we just brought back after the surgery to look at it.
You think that's much of an osteophyte?
No, I really felt that this was the AC joint, and that was just a little bit of widening of the acromion at the AC joint, which was on the next cut. But surgeon,
I don't think I would touch this acromion.
Yeah.
Now, one thing, it is like between type 2 and type 1.
Yes.
More type 1. And what I like to ask one of the fellows is, which type of acromion gets operated the most? Type 1, 2, or 3?
I would guess.
I'll take volunteers.
It's Samuel. I would guess 3.
3s are pretty not that common.
Yeah, we guess 2 just because they're more common. 2 possibly because they're more common in general.
Pardon me?
I said the type 2s just because they're probably more common in general than the 3s.
Precisely. Type 2 is by far most common, so that gets operated the most. The thing is, nowadays it's not as, we don't operate on these as often as we used to. When Neer came out with his article, everybody and his uncle was on the table getting operated on. And these operations didn't turn out all that great. So,
John,
anyway.
I recently saw, and I forgot where it is. I need to look it up again. Published somewhere in the orthopedic literature that they did a survey in the United States of how frequently acromioplasties were done, and I think it was based upon billing data that were sent in for reimbursement. And it's what and I don't see this in Southern California, but what they were saying is that about over 50% of patients that go in for arthroscopic repair of a rotator cuff also get a chromioplasty. I think this is the last 3 years in the United States. I don't see it that common.
You're right. Near started quite a
process. Yeah.
Quite a process.
Yeah. So let's see. Thomas, what do you think? Let's see. Who's Sahar's next? Sahar, what do you think of this one?
Okay, we have single coronal view of the shoulder, and we have, let's say, moderate hypertrophy of the acromioclavicular joint.
Okay. So what?
And some.
So this really isn't bony enlargement. This is actually callus formation at the acromioclavicular joint, and then notice that the proximal aspect of the supraspinatus tendon has a little bit of increased cellular intensity compounded with tendinosis, where the distal tendon is still black. So this is, you can just get fibrous hypertrophy around the AC joint, which can also press down upon the supraspinatus tendon and cause irritation to the supraspinatus tendon as well. So AC joint callus can also do it.
Mm-hmm.
Well, with the supraspinatus muscle mass, it looks like this fellow is doing a lot of exercise. So maybe he should slow down a little bit.
Yeah, maybe so. Okay, Thomas, what do you think of this case?
So there was lobulated septated cystic collections superior to the acromioclavicular joint, and there's osteoarthritic changes of the glenohumeral joint.
Yeah, complete rotator cuff tear, superior migration of the humeral head, which we'll talk about. The humeral head is way up here. It should be articulating with the glenoid here. And the main thing I wanted to point out here was, what about this big cyst?
Yeah, so these would be consistent with the geyser lesions of the acromioclavicular joint.
Yeah, so some people call these the geyser sign. It's just a cyst that emanates from degenerative disease of the acromioclavicular joint. It's just, again, it's important that in, I think, all three planes of the shoulder, it's important to make sure not all the sequences are fat suppressed, because fat is very valuable to let us look at a lot of anatomy. There are a lot of places that only do fat suppressed images in the oblique coronal plane, but even on a T2 weighted image where we can see the fat, it really allows us to better look at the morphology of what's occurring here, the size of the osteophytes, and the amount of pressure effect upon the supraspinatus muscle. So when you go out in your practices, don't fat set everything. And those of you who went to the Curl and Job lecture last week, that was the first thing that Scotty Kingston said in his lecture, because he's found the same issues from outside studies that are sent in. So fat is your friend in the musculoskeletal system. Okay, let's see. Thomas, you did the last one, right? Sam?
So the radiograph and the MR, I think they show pretty much the same things. AC joint degenerative changes in a large osteophyte inferiorly, and I guess yes, indenting the superior myotendous junction.
So this was back around 1990. We used kind of an experimental protocol that flunked, because you can see all the noise on this, but it was good enough where you can actually see the osteophyte indenting the supraspinatus muscle and tendon. This person was very symptomatic. I had to hear about it all the time because he was my father-in-law at that time. And here are the sagittal images, which we can see here, and you can see it pressing down upon the supraspinatus muscle and tendon, producing outlet impingement. He was a big handball player, but for the first time in his life couldn't really play handball anymore. So he went in and had a Mumford procedure, where you just resect the distal roughly a centimeter of the clavicle. This was his x-ray after the Mumford procedure. Here's the MR after the Mumford procedure, and you notice there's no longer any pressure down on the supraspinatus muscle and tendon. It took him about 6 weeks to recover from the surgery, and for the first time in a couple of years, he was back playing handball again within 3 months of having the procedure, with his symptoms almost completely resolved. So impingement is a real factor. It's, as John is referring to, it's not nearly as common as people thought at one time, but it is a real.
You also notice that there's a little bevel of the clavicle downward, and that gives it more room for abduction.
Good.
You're not supposed to cut it just straight across. Great. You're supposed to bevel it.
Good. Thanks. Okay, and then here's someone who had a previous fracture, and you can see where there's impingement here due to the abnormal bone morphology, because the fracture healed inappropriately.
A good result.
Yeah, non-physiologically. And here's another example where we can see post-traumatic osteophyte and a post-traumatic osteophyte here in a patient who had impingement from the abnormal bone morphology. So moving anteriorly, let's talk about anterior impingement or coracoid impingement. And that's where you have a prominent coracoid process anteriorly, which can then impinge on the subscapularis tendon. And treatment for this is going to be a resection of the coracoid tip. This was a paper in 2004 which said it's not just the prominent coracoid tip, but actually the position of the coracoid, which is congenital. And if it's too inferiorly placed, then you have more likelihood of impingement than if it's higher in the normal position, and less likelihood if it's higher than above the normal position. So if you see, if you kind of draw this quadrangle here, and the coracoid is the tip of the coracoid really produces this bump angle inferiorly, they said that was increased the risk for having coracoid impingement. And you can kind of see that on MR. Here's kind of the normal appearance. The coracoid's a little bit high in this particular case. Here it's down a little bit lower. And if you kind of draw the lines, you get what they call the chevron appearance to the coracoid process. I usually just eyeball this. This alone I will not call impingement. You then have to look at the axial images, and you have to look at the space between the coracoid process and the anterior aspect of the humeral head. And you can measure this, and the cutoff for this measurement is around 7 millimeters. People with 7 millimeters or less tend to have increased risk for having pain and symptoms due to anterior impingement. If it's greater than 7 millimeters, it's less likelihood. This is someone who had an arthrographic injection through there. And so you also need to look at how laterally placed the coracoid process is. So if it's inferior and laterally placed with narrowing of this space, then you have increased risk for acromial impingement. You have to be a little bit careful, because if you have someone who has superior migration of the humeral head due to rotator cuff tear, you also may get impingement here, which, narrowing of this space, which may not necessarily be symptomatic. So that's the space to kind of look for. And then you also need to, before I call it, typically I might give this number and describe this findings in the report. But there's one other thing that I like to see before I call it impingement, and that's edema in this particular area, which I'll show in a minute. And this is more than normal. So you can compare the increased risk with narrowing of the anterior space here, the coracohumeral space, to the more normal appearance of the coracoid process with respect to the humeral head. So you can see that this is markedly narrowed compared to what the typical is. So this was someone who did have anterior impingement, and that's normal. This was a paper that we published a number of years ago, where we looked at these distances and people with different degrees of internal and external rotation. And here you can see a very narrow distance here, and someone who actually wasn't symptomatic. This was me. And then here we get more of a neutral on me, and then external we got less. But we kind of looked at this, and typically is what we found with, there was narrowest with internal rotation, and our series of people who had no symptoms, and internal rotation was about 10 millimeters, and then neutral and external. So there can be a big difference depending upon the rotation, and that's because the humeral head in that location is not a circle. Now in the wait, oops. Well, that's with different degrees of rotation. Okay, here are people who were, the same person was placed in different positions and rotated. Wait a second. Here it is. It's a paper that I was on now, and I forgot how to interpret the results. This is in the control group. Oh, I see. Let me. Okay, I'm sorry. Well, what this shows, this shows is when we put control individuals in the scanner and ask them to put themselves in internal rotation, neutral, or external rotation, we measured the degree of angulation based upon where the intertuberous groove is. And in internal rotation, there was a 10-degree difference between the plane of the glenoid and where the intertuberous groove was. In the neutral position, there was a 56-degree angle between those. And external rotation, the intertuberous groove was basically 90 degrees from the plane of the glenoid. So this just shows what the angles of the different degrees of rotations were in the control group. And then when we placed the people in the control group in different positions, is what we found is that the coracohumeral distance was narrowest in the neutral position. We thought it would be narrowest in internal rotation. They were about the same, but it was widest when it was in external rotation. Now, this was one individual, which was me at that time, and what we can find is that there was actually a big difference between my right and left, depending upon the degree of internal-external rotation. The right side here, which gets very narrowed and in internal rotation in this particular case, this was a case, the shoulder where I had a rotator cuff tear and a little bit of superior migration of the humeral head versus the left, which was normal at that time. So subacromial impingement is a real thing. And when you do measurements of this, it's important to take into account the degree of internal or external rotation of the humeral head. And the studies at that point had not taken the degree of internal and external rotation into account when they took this measurement. And if you just put people in the scanner, we typically ask them to be externally rotated, but a lot of patients who have real pathology in their shoulder have a lot of pain in external rotation, so you have to actually scan them in neutral or internal rotation. And therefore, if you do that, you have to take that into account when you do the measurement.
That's 7 millimeters for internal rotation?
That 7 millimeters is for a neutral rotation. Yeah. Okay. Let's see. You did the last one, Sam? What do you think of this one? Sure.
So 39-year-old male, rule out rotator cuff tear. We've got a single axial image of the shoulder. And it looks like the subscapularis tendon there's a partial thickness articular surface tear of it. And
we're in severe internal rotation here.
Significant internal rotation, and I'm looking for there's
cut up.
So the coracoid looks like the coracohumeral interval is very small there.
It's about 5 millimeters there, and it's very narrow in through here. And if we go a little farther up, we see this, and we go up to see there, and we can see you can also get impingement on the biceps with anterior impingement. And then a little thickened biceps there going up, and this was coracoid impingement. And you can see on the sagittal images, this is too narrow a space in this location. Great. Okay. Now, the thing I like to look for before I will call internal impingement, unless I have some clinical evidence to support it, is bone marrow edema right in this location. And here we can see the coracoid process, and another slice that was a little bit more narrow than that. But what you can see here is the bone marrow edema and the lesser tuberosity. Now, you can get marrow edema here occasionally from traction injuries from the subscap, but they tend to be over here. This is right in the area where you get impaction against the coracoid process. So you need to have the chevron sign, you need to have narrow space, and then bone marrow edema in this location. Those three things would make me suggest the diagnosis on an MRI imaging, even if I didn't have further clinical information. So this was anterior impingement. Okay. And then here we can see another example. See where the biceps tendon can get caught in between these two. We can see the bone subcorticocystic changes here, the typical tear pattern of the distal subscap, sublux biceps tendon, and the narrowed coracoid space here. Another patient with subcoracoid. Another name for this is subcoracoid impingement. Now, this is kind of closely gets confused sometimes with something that we see commonly in overhead throwers, predominantly baseball pitchers, and that's GIRD, glenoid internal rotation deficit. This is seen only in high-performance throwers. It's due to extreme forces on the humeral head in the late cock and early acceleration phase of throwing. And you get an impaction on the posterior superior humeral head against the glenoid, impingement of the rotator cuff. Well, actually, this is often associated with it. This would actually be more posterior impingement. But we'll be going through this a few more times. This is the Job classification system for the different phases of the throwing mechanism. And the main one that produces the problems is this one. It's the late cocking phase, right in through here. And here's just, so that was a few years ago where we were playing the Boston Red Sox, and that pitch, the ball just went over the fence for a home run. But if we go through this and let me see, oops, here it is. Let's kind of go through the phases. So you can kind of see this is, the hands are together, the hand wind up, the hands separate, which is a key point, and then we have the early cocking phase, and then the late cocking phase, which is right there. Whoops. Okay, so all of you now try to put your arm in that position. If you can't put your arm in that position, unfortunately, you'll never be a Major League Baseball pitcher. And the reason for that is, as we'll see in the next frame of this, what happens here is that you've got acceleration of the ball to the release point, which will be right up here. Now, if you're like me and you can get your arm back to there, you get very little space here to put acceleration on the ball. So I can throw a fastball probably about 20 miles an hour. In order to be a Major League Baseball pitcher, you've got to hit around 90 miles an hour, as you all know. So in order to do that, you have to have the ability to hyper externally rotate your shoulder. The elbow's involved in this, but this is mainly at the shoulder. And none of these pitchers can get in this position with their non-throwing arm. And what happens then is that you get a rotation of what your rotation is, so that you cock much farther back, you release the ball up here, but if you go forward, I can rotate my arm so that my arm can basically hang down vertically to the floor. He can only get his shoulder rotated to about here. So what he has is internal rotation deficit, because he can't internally rotate the way we can. And that's because he has basically the same range of rotation, but it's all cocked back again, which allows him then to put a lot more momentum on the ball to be a pitcher. This is something that is acquired. It occurs between 11 and about 15 years of age. And if you're not pitching in that time frame, it's virtually impossible to be a Major League Baseball pitcher, because that's when soft tissue and bony changes occur in the throwing shoulder, which allows you to get into this position. So we can look at the next frame in this. He moves a lot. Oops, come on. What's going on here? That's the next frame. And you can see he's already started to release the ball. There's the ball right there. And then if we continue, oops. So there it is in real life again. So we're going to talk about that. So basically what happens with Major League Baseball pitchers and quarterbacks, to a lesser extent, is that the entire shoulder range of motion rotates so that it's more posterior, which allows them to have a much larger area where they can put momentum on the ball and throw a faster ball. This just shows, if you compare it side to side, the dominant side, you basically have the same overall range of motion. It's just shifted back. So a lot of these people get into pain, and there are several different theories as to why Major League Baseball pitchers tend to have so much shoulder pain. And this rotation deficit. Frank Jobe, for a while, felt that it was stretching of the anterior capsule, and they developed anterior pain due to being put in that extended position so frequently they'd stretch the capsule and they would become unstable. And there was a surgical procedure, application of the anterior capsule for that. Morgan on the East Coast felt that it was really thickening and scarring of the posterior capsule, which kind of pulled everything back again in that particular time. And he had a surgical procedure to correct that as well. If you actually do measurements on the morphology of the humeral head, you find that they're asymmetric in baseball players, with the dominant humeral head changing in a configuration which actually allows the elbow, allows the shoulder to hyper externally rotate. And so there are actually bony changes which occur. And then you can also measure soft tissue changes as well as these in these individuals. It's generally felt now that there really is no good evidence of a capsular contracture to cause this, and it's generally thought that it's not really stretching so much of the anterior capsule anymore. It's really retroversion of the humeral head, the proximal humerus, that allows most of the rotational shift. So let's see. Okay.
I think that birth has something to do with it. It's a congenital condition. Out of 100 kids, you might find like 10 that may be able to throw a ball and be pitchers in the future. But I doubt if it would be more than 10.
Yeah, I think there's certainly a genetic congenital aspect of being a good pitcher, but what we're talking about here only occurs in the dominant arm and develops over a pretty limited time frame in teenage years. So I think the GERD itself is acquired, but you have to be a rare physical specimen to be a Major League Baseball pitcher, regardless.
We also have bilateral pitchers, so they also pitch very well. They're right and left-handers, switch pitchers.
Okay, yeah, I'm not familiar with those. Yeah, I can.
You don't see very many.
Right.
And like the batters, you can hit.
Yeah, certainly see it in batters, switch hitters. Okay. So this just shows that the arc of motion just shifts in pitchers from being normal, like most of us anyway, unless we have any pitchers in with us, to much more hyper posteriorly rotated. And I was actually in San Francisco for a meeting 15 and 20 years ago, and I just started reading the sports pages of the local paper, and I came to this article, which made me a little bit upset. But here was Bruce Jenkins, and he was saying how terrible it was that Major League Baseball pitchers no longer pitch total full games. And this is just a chart showing that it peaked in 1971 with the most number of complete games pitched in the Major League. And then it trailed off to, at that particular time, so 2009 or something, 2010, it had fallen significantly. What he didn't mention in the article, which should have gone along with this graph, was the longevity of a Major League Baseball pitcher. And it went the other direction. It went from only a few years to many more years pitched. And also, he should have had a graph of injuries. And there's a lot of data now to show that your risk of getting injured pitching is directly proportional to the number of pitches you throw. It's not just the pitches in the game, it's kind of also practice pitches count as well. So what's happened during this time period is that the Major League Baseball teams, especially in the 70s, realized that they were spending millions of dollars, a lot of money on these pitchers, millions even in that particular time. But some of their best pitchers had the shortest life expectancy. And so they started watching pitch counts and also watching any symptoms pitchers had. And by taking them out of the game when they reached certain pitch counts, or if they noticed certain mechanical changes in their mechanics or any symptoms that they had of pain, that they took them out, that they could preserve their asset in that pitcher much better. And therefore, the number of total full games went down, but the health of the pitchers really went up during this time period.
Did they assess the speed of the pitch?
Not in this article, but
that'd be interesting to see.
Well, in real life, they follow the speed of the fastballs, and when there's the fastball speed drops below a certain amount for a given pitcher, that's an indication that they're getting fatigued, and they'll take them out of the game to preserve their arm. Yeah, there are factors that go into play for that now. So anyway, the next thing I want to go in through is really now, and the treatment for this now, typically nowadays, the way that this is treated is that as soon as the pitcher comes out of the game, they go into the locker room and they ice the shoulder virtually every time they pitch. And then for they typically are off for 4 days if they're a starting pitcher. And during those 4 days, they do stretching exercises to kind of try to bring the rotation back into a little bit more normal. And then typically they feel much better 4 days later. So the general feeling now is that this rotation is a normal physiologic response to pitching, and that the symptoms are more due to overuse of the tendons. And icing tends to help, and they tend to get back normal range of motion in their normal plane, in their normal location, by about 4 days after they pitch, and that's why the current rotations are typically every 4 to 5 days. So there are reasons why that's the case. So why don't we stop here, and let's talk about posterior impingement on I'm not sure whether we're going to have lecture tomorrow or not. I'll let everybody know tomorrow afternoon.
You're off tomorrow.
Well, it's kind of a short week, so I might work tomorrow afternoon. If so, we'll have lecture. If not, we'll have lecture on Thursday, and then I will not be here on Friday. So I'll
you better talk to Melinda before you commit.
Yeah, you're absolutely right. You're absolutely right. I will talk to the wife. All right.
Okay.
So
have a good evening.
Okay.
Have a good evening.
Thanks, everyone.